for the introduction. Thanks for you to stay until the very end of the Congress. So, which dose antibiotics in case of renal replacement therapy? As I said yesterday, because I made the same presentation for the nurse session, when you give antibiotics, you need to give an appropriate and adequately. Appropriate is just the antibiotic which is effective in vitro against the pathogens. Then the complex challenge in that case is that, of course, identify the microorganism and potentially deal with resistant pathogens. But the treatment that is adequate means that is able to achieve adequate, sufficient drug concentration to treat the pathogens in the blood in the site of infection. And this is difficult, this is a challenge, because the presence of a renal replacement therapy and the presence of a critical illness can alter antibiotic pharmacokinetics. And change in antibiotic pharmacokinetics will alter concentration of the antibiotic. So when we start a renal replacement therapy, we can affect drug concentration because both the ultrafiltration or the diffusion procedure and only the unbound antibiotic, the molecule which is not attached to the proteins, will be filtered by the device. And this will, of course, significantly alter circulating drug concentration. Just to make you an example, in green you have the time course of drug concentration, whatever will be the antibiotic, in patients with a normal renal function. You have the peak concentration, the area under the curve, AIC, and the minimal concentration, which is the concentration before the next dose. When you have an acute kidney injury, for those drugs that are hydrophilic, which means 80 to 90% eliminated by the kidneys, you will have this phenomenon of accumulation. So the peak concentration is not influenced, but the drug will be slowly eliminated, and this is why we tend to reduce the dose after a few days or to widen the interval between the next dose. If you apply the renal replacement therapy, of course, this is not effective as a normal kidney, so you will remove a part of the circulating antibiotics, but there will be something between a normal kidney and an acute kidney injury situation. So, of course, you cannot give the same dose than the patients in normal renal function. So, when we want to prescribe antibiotics, usually we use systematic review of the literature, where some authors evaluated studies and tries to summarize what happens and which is the best dose in this situation. This is one of, I think, the most recent paper, already almost 10 years, published in CID, Trotman and co-authors, that review the literature and try to summarize, to give you some advice how to manage drug dosing, antibiotic dosing in this setting. And you see, for example, I put in red some arrows. Cefepime is 1 to 2 grams every 12 hours, which is not the same dose than a normal renal function. It's 2 grams every 8 hours. Meropenem is 1 gram every 12 hours. In all the situations, they recommend lower dosage than patients with normal renal function, which is, of course, logical. But the question is it so simple? Can we think that one fixed dose, as Louis said before, would produce adequate concentration in all critically ill patients on RRT? And in this study, an Australian group evaluated concentration of glycopeptides, beta-lactams, in critically ill patients. You see the number of patients that were measured was not very high, but the important findings from this study is that there was a huge variability. You cannot use a fixed dose and pretend to obtain adequate concentration in all patients. There will be huge changes, and there are some patients who will have sufficient drug concentration and some would not. And whether or not this insufficient concentration can influence outcome of patients, we don't know, but this, of course, may have some influence, for example, on the occurrence of resistances. And this variability is due to what? First, to the device prescription itself. You may imagine that the intensity, the dose of CVVH can influence the clearance of the drug. But also the time of CVVH, some membrane, you will see now in the next slide, and some factors related to the patient. Concerning the device, the coefficient of sieving, which is the capacity of a drug to pass through the hemofilter, will be dependent essentially on 2 factors. One is the molecular weight. Teicoplanin is a very high molecular weight, is not very well eliminated by CVVH, by the renal replacement therapy in general. And protein binding. If a molecule is highly linked to the protein, like oxacillin, the possibility that your RRT will eliminate this drug is very poor. Other problems, you may have some absorption. If you give aminoglycosides, some fraction of amikacin, for example, could be linked to the membrane, and this will reduce drug concentration. And finally, residual clearance. Some of our patients will keep some urine output. This will add some renal clearance to the device clearance. And if you did, for example, for piperacillin, which is a 10 to 15% biliary extraction, you cannot calculate this just looking at the ART setting. And the other point that can influence drug concentration is not the device, but the patient himself in the ICU. We will reanimate, we will give fluids to these patients to stabilize hemodynamics. This will increase the volume of distribution. Many of our patients have an increased body weight. An increased body weight can significantly, again, increase the volume of distribution. And the consequences are that drug concentration in blue, which is in healthy volunteers, normal patients with a less severe infection, compare with the patients in green who is critically ill, there will be a reduce of the peak concentration because the volume of distribution is increased. And is it important? Yes, because aminoglycosides are effective due to the peak concentration. So you have to increase the dose of aminoglycosides to achieve the same peak concentration than a patient who has less severe infection on healthy volunteers. And the time that the concentration are above a threshold of sensitivity, for example, the MIC coming from the lab, is lower because of these PK changes. Is it important? Yes, beta-lactams are effective because of prolonged time above the MIC. So if you reduce this time, the beta-lactam effectiveness will be reduced. So which are the consequences? How to optimize drug concentration? I will just take as example aminoglycosides and beta-lactams, and of course, many other things could be discussed for other drugs. You just increase the loading dose to immediately optimize drug concentration. The loading dose is independent from renal function. So which are the best doses? Which are the optimal doses? For beta-lactams, honestly, we don't know. What we have shown is that in patients with critical illness without RRT, we need probably to double the dose of broad-spectrum beta-lactams to immediately achieve drug concentration. Whether this is true for patients in RRT today, we don't have real data in real measured patients. So I cannot say this is the truth, but this should be tested in future studies. Concerning aminoglycosides, as the dose is independent, the loading dose is independent of renal function, we have to give the same dose in patients with normal renal function. We have already published data that to optimize peak concentration, you have to increase amikacin dose to 25, 30 milligrams, kilograms of loading. And we have also shown that in a subset of patients with RRT, the first dose of amikacin is exactly the same in terms of peak concentration. We give a higher the standard regimen, 25 milligrams per kilograms, and we obtain in 70% of patients an adequate peak concentration, which means that in some of them you have to give an even higher loading dose. Of course, you may expect that RRT is not effective as a normal kidney. There is some accumulation. And if you want to give the next dose, you have to wait not 24 hours, like in normal situation, and maybe 2 days. So you'll be effective because you give the right dose to have the adequate peak. Then you have to wait more time to give the following dose. What about optimize daily doses? You give the loading dose, and now to optimize the daily dosing. For beta-lactams, what we did is that we applied in our patients in Brussels the recommendation of Trotman and others, and we measured drug concentration. You have in green piperacillin, ceftazidime, cefepime, and meropenem, and this is the percentage of patients with adequate concentration to empirically treat difficult-to-treat pathogens, for example, Pseudomonas. And you see that the results are not very positive. Most of these patients are insufficient drug concentration. And because of a drug accumulation, the situation is much better after 48 hours. So in the early phase, the conclusion is that you cannot strictly apply the recommendation on the literature, but you have to modify a strategy, which means probably give unadjusted drug regimen, the same drug regimen that you will give in patients without RRT or AKI. Does it work? We changed our practice in Brussels and we validated in an observational study measuring beta-lactams concentration in patients on RRT that received unadjusted drug regimen, the same regimen that patients with normal renal function. And in gray, you see the proportion of patients with adequate drug concentration. We reduced from 45% to less than 10%. So it works. If you adjust your daily doses, you will increase the number of patients with adequate drug concentration. What we have learned from this study, this observational study, is that there is no correlation, or very poor correlation, between the intensity of CVVH and drug clearance. So in other words, if you don't measure drug concentration, you cannot predict which patients would have adequate drug concentration. The second point is that as we increase drug regimen, and there is a phenomenon of accumulation, after a few days, you will have some patients with a very high beta-lactams concentration, which of course are not effective in terms of bactericidal activity. Is there any possibility of toxicity? Maybe yes. So after having increased your daily doses in the first hours of days of therapy, then you have to reduce it again to recommended regimens to avoid this potential accumulation. Of course, you may say, I gave my unit continuous infusion. So it's not what you showed with intermittent infusion. What should we do? Which is the best drug regimen when you give a continuous infusion on RRT? Only 2 studies have been published, both from Australia. They show that if you give meropenem 3 grams a day, which is again the same dose you would give in normal renal function, well, it will produce 100% of patients with adequate drug regimens. For piperacillin, if you apply Trotman recommendation, 8 grams piperacillin per day, you will have 87%, and only 60% by intermittent infusion. So in that case, if you give piperacillin, 8 grams will be enough, but only if you give it by continuous infusion. What about aminoglycosides? I told you, if you give aminoglycosides, then you have to wait maybe 2 days before giving a next dose. What we have shown in this study is that if you increase the intensity, the dose of CVVH up to 45 milliliters per kilogram, which is very high, you are able to remove a great proportion of circulating aminoglycosides. And then you are able to give a high dose, which is what you want to do for Pseudomonas, and you can remove sufficiently the drug, and you are able to give in 90% of patients the drug regimen the next day. So you have a daily administration of a high-dose aminoglycosides. And in those patients who survive these multi-drug resistant pathogens, we have 50% survival with multi-drug resistant pathogens. Most of these patients recover normal renal function, despite we give a lot of aminoglycosides. Of course, I focused my talk on continuous therapies, because most of the literature relies on continuous therapy. What we do today for intermittent dialysis is that we apply the same recommendation coming from the literature in patients coming with the hospital as an outpatient. Of course, I showed you these patients have not the same pharmacokinetics, the critical illness. So can we think that those drug regimens validated in this setting could be valid in our ICU patients? I don't think so, but we don't have data in that setting. And finally, now we have this kind of extended intermittent daily dialysis application, the EDD, the SLED application, and less than 1% of drug have been tested in this setting. So we don't have any proposal. Just to give some example very rapidly, aminoglycosides. If you use a SLED, so an extended daily dialysis, then you see that the removal is quite slow. You need to wait at least 2 days before giving the next dose. That could be a problem if you want to use daily your aminoglycosides against, for example, Pseudomonas. The second point is concerning timing. Should we start dialysis during the administration or after the administration? You can see here on the right side that the peak concentration will not be affected at all if you start a SLED during the administration or thereafter. What will change is the accumulation of the drug. If you start SLED after the end of the infusion, you will have lower true concentration than when you start before. So if you want to give it daily, please give the drug, start your SLED thereafter, and wait for drug elimination. Finally, for beta-lactams, what we know today is that there is a huge variability of meropenem concentration, for example, in patients undergoing SLED. So it's very difficult to predict in those patients which is the best concentration. If you give a continuous infusion and if you give a SLED, you will, of course, induce a transient decrease of the drug concentration with a recovery somewhat thereafter that can influence, of course, the time that these concentrations are above the MIC, because you have, of course, a specific moment when you are effective, and then you have a recovery of drug levels thereafter. And these are at least 2 editorials that suggest that drug dosing during SLED is very difficult, particularly for beta-lactams, for time-dependent antibiotics, because you have so few data, it is impossible to give some advice or kind of idea on how to better prescribe in this setting. So to conclude, you may be very good in pharmacokinetics, which is not my case, and you are able to apply this complicated algorithm to calculate the distribution volume, drug clearance to CVVH, and to immediately prescribe the best drug regimen to your patient. These have never been validated in ICU patients. This is kind of a hypothetical approach, but as you heard before, there is a so huge variability in these patients that if you don't measure, you cannot apply just formulas. My message is that RRT and patients' characteristics affect antibiotics PK and concentration in our patients. If you start a continuous RRT technique, you have to give the same loading dose than in patients without RRT or without any acute kidney injury. Then in beta-lactams, you have to use unadjusted dose in the early phase, just to reduce the dose after 48 hours, especially again if you deal with difficult to treat pathogens. If you have very susceptible pathogens, regimen doesn't apply. For aminoglycosides, you can increase the intensity of CVVH to potentially give daily your very high aminoglycoside dose. Finally, in case of SLED or intermittent dialysis, honestly, I don't know, because we have very few data in critically ill patients, and my fear is that we can deal with insufficient drug concentration if we just rely to this non-critical illness literature. So if you can, please do TDM to adjust your therapy. Thank you.